Hello, everyone. We're going to go ahead and finish up here. We've got a couple of things we're going to finish with. Our next speaker is Dr. Mark Applebaum. He is an associate professor in the Department of Pediatrics, Section of Hematology Oncology, and Stem Cell Transplantation at the University of Chicago. He received his BA in Molecular and Cell Biology from the University of California, Berkeley. He received his MD from Northwestern University, Feinberg School of Medicine. And he completed his residency at the University of California, San Francisco, and his fellowship back again at the University of Chicago. He is the author, co-author of numerous papers, articles, books, chapters, and other works, and a member of various professional associations. His talk today will be on liquid biopsies, what they are they useful, where and when. Dr. Mark Applebaum.
All right, thank you, Pat, for that wonderful introduction and the invitation to speak today. And of course, thank you all for sticking in there. And it's been a lot of information today, a lot of great speakers, a lot of great discussions. Really happy I get to be a part of this. Hopefully we can start another good discussion about the topic of liquid biopsies today. No disclosures. I will say, although Carol just walked out, it looks like, that I really do appreciate her comments on what it takes to fund these studies, what it takes to do these studies. This really is a lot of effort from a lot of people, a lot of tax dollars at work to really do make all this possible. I was also recently helping run a meeting, the American Society of Clinical Oncology. I encourage all of our speakers to lead with the end. Apparently this helps everybody remember what you're doing, and also if you remember nothing else, we have the conclusions here at the beginning, just as sort of the key takeaways of what I'll be talking about to hopefully frame the discussion. First, liquid biopsy. It's really a fancy term for a blood draw. My wife is an OB-GYN. She likes to just yell at me like, "You're just getting blood from kids." It's not that exciting. But what is exciting about it is the biopsy term, right? It's a way to actually try to understand what is going on with the biology of the tumor, the metastases that may or may not be present, the tumor environment, really wrapping up many of the things that have already been discussed today in terms of whether that be MYC-N, whether that be GD2, if we talk about ALK, all these concepts that play a role in patient care and decision making. We really hope to sort of encompass everything you might think about with looking at a piece of tumor. We are working on trying to figure out how do we actually do that with a blood draw, right? Because a blood draw is obviously much more simple, much easier than looking at tumor. We also think liquid biopsies hold enormous potential for monitoring disease. As was discussed earlier today, really the standard right now is MIBG scans, it's CT scans, bone marrow biopsies, which, as everyone here is familiar with, we can only do every so often. Blood draws, we can get pretty much as often as we want. And I think hold enormous potential, and I'll highlight the word potential there, for monitoring patients, and also for potentially selecting therapeutic options. However, there are several unknowns that we are working on actively in this field. What are the best tests? When do we get these tests? How do we interpret those tests? And how do we really use this information to make treatment decisions? I think is still a very active area of investigation that I'll discuss a little bit more. So you've seen this slide already. This is a courtesy of Dr. Cohn. Ami Desai presented this earlier. A lot of what we use clinically is very, standard. We've known for a while. You've heard about MYC-N. We've talked about histology and stage and age. You've heard about copy number already today as another method for helping risk stratify certain subsets of patients. But where liquid biopsies really are focusing on is really sort of the newer stuff. Things like germline variants potentially, other omics signatures, whether that be RNA-based, whether that be DNA-based, as well as actionable mutations, things like ALK and other variants that might be of interest for therapeutics. And I want to start by highlighting why we think liquid biopsies is potentially a very opportunistic way to go about looking at tumors. This is a figure from a landmark paper. It was published now about 10 years ago, or 12 years ago, excuse me. Been cited almost 10,000 times in the literature. So this was one of the very first sequencing studies where this was an adult with kidney cancer. And the investigative team here took the primary tumor, which you can see on the top left, and they took the DNA very specifically from 8 different sites of the primary tumor. They also took DNA from different metastatic sites and sequenced all of those sites individually, right? And what you're showing here on the bottom is there is a lot of heterogeneity or differences between all the different places. So if you look at the bottom of the screen, if in the blue there's ubiquitous, that's about 25% of the variants or the mutations that they found were actually common to all sites of disease. It's only 25%. Some were shared amongst the primary, that's another 25%. Some were shared only amongst the metastatic sites, and about 25% were actually private to the individual biopsy that you got. Right, so as I say in real estate, right, location, 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 right? So where you biopsy matters. This is why we do multiple bone marrow biopsies on our patients, because we know that sampling effect is real. If you take one piece of a tumor, it might not look exactly like another piece of a tumor just because that is how tumors evolve. This is showing up a little bit funny. Pretend that the bottom there is on the top. What I'm trying to show you here is tumor evolution, right? We know that a tumor in diagnosis is not the same tumor that you might see at relapse. And this is a concept that I think has already been touched on today. This is an example from leukemia, where they're looking at hematopoietic stem cells on the left. And as the tumor develops, right, you might see 3 or 4 different mutations in different subsets of those leukemia cells. That's what you're seeing in purple or yellow or orange. As that tumor gets treated, some of those clones, right, some of those specific clusters of mutations might be cured with that therapy, while others might persist. And that clone might itself spawn other clones. So that's what you're seeing on the right, which is actually perhaps that relapse-resistant clone at the end. And so really the genetics of what's going on in the tumor, or the epigenetics, or really whatever marker you want to look at, we know can change over the course of therapy. And if we're thinking about neuroblastoma, where we primarily have biopsies at diagnosis, it's going to be really hard to look at this, right? It's, if not impossible. And so here's where I will say the promise of liquid biopsies comes into play. And this is a figure from a review article that we published. The blood is sort of a homogeneous hodgepodge of all sorts of things. So blood, of course, carries red blood cells and oxygen. It carries nutrients around your body. But there's also a lot of other stuff we can find in blood. Specifically in the context of cancer, there's lots of things that we can find, particularly from metastatic cancer. We can find circulating tumor cells, these CTCs in the bottom left, right? So there's technology, and I'll get to that in a little bit, but it's a little bit more in development, where we can try to capture actually what are the cells floating around in the blood. We can look at these small vesicles called exosomes. But more importantly, where I'll really focus most of my talk is we can actually get DNA that came from inside a cell that's floating around in the blood. We can also look at the RNA that's floating around that are from cells. So we can actually, it's very straightforward these days to draw a tube of blood and isolate both the DNA and the RNA, which is where we'll be focusing, the majority of my talk here. And in this way, right, because we can get blood frequently, multiple times a week in some cases, although perhaps not for these assays, we can ask lots of different questions, right? We can ask, can we do early cancer detection? I think for neuroblastoma, that's probably less important, but if you're thinking about many adult cancers or other sort of cancers later in life, this is a very big field with lots of companies developing technologies for that. Molecular profiling at diagnosis, right? As I said, we get a tumor biopsy of the primary site. That may or may not be exactly what the metastases all look like, but by looking at the blood, perhaps we can get a better sort of global sense of what variants we might see circulating in the blood. One of the important things we can do is perhaps detect minimal residual disease. For many in the audience, and especially the clinicians, will tell you our scans, our bone marrows are not perfect. People who are in a complete remission or have a complete response will unfortunately relapse. And we know some kids who actually will have residual spots on their MIBG scans who will live a very, very long time with residual spots on their MIBG scans. But can we use a blood test to actually say that a little bit perhaps more precisely? can we use that for monitoring, right? And look at these tests over time. And also, as patients unfortunately relapse or have recurrences, can we figure out why, right? Can we look at the difference of what did we see in the blood that was there at the relapse that we didn't see at diagnosis? And so this has already been described a few times in terms of how we treat high-risk neuroblastoma. And really, our biomarkers and ways for tracking disease are, as I mentioned, very limited, right? At diagnosis, we have our biopsy. That's shown by those small round blue cells in the top left. We have our MABG scans. And really, the only sort of prognostic indicator we have to how well a patient is going to do is, do you respond to your chemotherapy? Right? So it's been shown by Naveen Pinto, who's going to be speaking tomorrow, and others, that if you've had a good response to therapy, after induction, you're going to have those patients, those children will have better outcomes than those who don't have a good response to therapy. This makes sense, but I would also argue it's a very crude tool. What if instead we could get blood draws, right? We can get DNA, we can get tubes at every single cycle of chemotherapy. We can look in those tubes and we can say, what is the DNA that's there, or RNA, and what does that tell us about in a patient's disease status? And really this is, I think, sort of the end goal, to have these tests available for patients. Of course, and also augmenting what we do currently as well. And so to do this, as I mentioned, right, there's a lot of different things we can look at. There's a lot of things that different research groups are looking at, including my lab. We can look at circulating, and really I've just shown you here sort of the common things people are looking at and sort of, I would say, the most advanced tests. We can look at things like circulating DNA, right? This is coming from the nucleus of the cell. And we can look at targeted genetic panels. This is particularly being pioneered by the Mosé lab over at CHOP. I'll show you some of that data in a second. We can look at non-targeted genetics in terms of just looking at all the DNA that we find. A lot of that work in neuroblastoma is being done over in Boston by Brian Crompton, and I'll show you a little bit of those data as well. My lab is particularly focused on epigenetics in terms of these 5-HMC profiles, which I'll also discuss. And then there are labs that are looking at circulating RNA. Dr. Marichellian, who I think will also be speaking tomorrow morning, has done a little bit of that work. But I would actually say that our European counterparts are much more advanced in terms of that. And also circulating tumor cells. There was a question earlier about looking for GD2. I think this is perhaps where that might be possible. But again, I think it's very, very early days to look at what's going on in the circulating tumor cells. So just to take this through one sort of analyte at a time, just to sort of walk you through what is being done and what we know and how this may help patients. So this was published by Esther Burko and Yael Mosé last year. This was using cell-free DNA that was from a study of ALK inhibitors for patients with ALK mutant relapsed neuroblastoma. And the clinical outcomes of this were published separately, but these were the biomarkers from the cell-free DNA. And they showed several different groups of patients, some who they could see lots of ALK variants or ALK mutations floating around in the blood. The bigger the circle here on these diagrams, the more they saw that ALK mutation in a patient's blood at any given time point. And you can see as you go through all the various courses, there's 4, 5, 6, 7 different assessments of how these tumors are responding to this therapy, right? Sort of gives you a hint of how we may be able to watch these things serial over time. There are some patients who they didn't detect ALK. Those are those group 3s for reasons that weren't able to detect it in the circulating blood. And some whose perhaps clinical response didn't always correlate to their ALK mutation status that they could pick up in the cell-free DNA. So, I think still more to learn, but I think a really nice concept that we can actually track response to a specific medication using a very specific test to help understand what's going on with our kids. Also in this paper, right, they weren't just looking at ALK, they were looking at a panel of several other genes that are commonly mutated in neuroblastoma, also mutated particularly at relapse. A lot of these genes are prototypical that you might see here are actually in the RAS-MAP kinase pathway. This is a growth pathway that we know has been shown to be mutated in many relapse tumors that we don't see at diagnosis. And this particular panel, which I should say, I believe has just recently received CLIA/CAP certification and I think is being clinically utilized in CHOP. So this is something where you can send this test. They've been working with Foundation Medicine. They got the result back, and this is something that can actually go into the medical record and be used to help sort of guide precision medicine options for them. Talking about the idea of tumor evolution. So there's several different ALK mutations that one can find. And in some of these patients, if you look at patient 2, they show that several new ALK mutations are found over treatment with an ALK inhibitor that might confer resistance. They can see additional mutations in P53, which is another well-known tumor suppressor gene. New mutations in RAS-MAP kinase, if you look at patient 26 or 43. And so if we serially collect these samples and serially look for these different mutations, we can understand a little bit more about how tumors overcome some of our targeted therapies, which also then we can go back into the lab and say, how do we sort of re-engineer our drugs, re-engineer our strategies to target these resistance mechanisms. I'm going to go a little bit now to what we're learning from ANBL 1531. As was discussed, this was the recently closed trial for newly diagnosed patients with high-risk disease. Steve Du Bois was the lead PI for this study. This trial, I'm happy I had the foresight to collect blood at lots of different time points. At diagnosis, before the first cycle, right after the first cycle of therapy, right after the second cycle, third cycle, fourth cycle, end induction, before stem cell, after stem cell, before antibody and after antibody. So we have lots and lots of time points, serial collected for lots of different patients. And this is, I think, really the power of cooperative group studies. What I'm showing you on the right is the pathway that this blood took, right? So, as many know, in children's oncology group studies, those samples are coming from hundreds of hospitals around North America. They all actually then went to Ohio, to the Biopath Center, where they extracted plasma. This is where the DNA is actually found in the blood. That plasma was actually then sent to Boston, where the Crompton lab is. They extracted the DNA, and they actually sent some of that DNA to us in Chicago, I think really highlighting really the team effort that this takes, as well as that concept that was, I think, presented very early this morning about learning as much as we can from every single patient that we see so that we can do better for our future patients. And for this, I'm going to talk a little bit about what's being done on the ANBL 1531. I would ask that none of these data, these are all preliminary data, not to be posted, so thank you for respecting that. But so just to highlight, right, so from these one tumor blood and neuroblastoma studies, and I'm actually, we are trying to collect circulating tumor cells on this, and I've cut out some of the other things that are being done. But in terms of the most advanced analysis, right, so some of this is coming to our lab, and some of the copy number as well as the mutation calling is actually being done over in Boston. And again, this is some of the work being done by Brian Crompton. This is his postdoc in the top right corner who's been doing a lot of this analysis. Similar to what I showed you in ANBL 1531, they've also collected samples from relapse and are very nicely able to show that in those relapse samples, they are seeing more of those RAS-MAP kinase mutations that we are able to see evolve over time. So really, taking another sort of focus, as I just showed you with some of the targeted paneling, about how can we actually understand the tumor evolution and what neuroblastoma is doing as we treat it. And I'll get a little bit into the epigenetic work that we're doing. A little bit of background, because this, I think, becomes a little more complicated than, is there a mutation in ALK? Is there a mutation in, is MYC amplified? Here we're looking at this epigenetic modifier, so really a modification to the DNA, right? So your DNA is your coding sequence, your ACs, Ts, and Gs. Those are the same AC, Ts, and Gs that you will have in every cell in your body. Every cancer cell has the same basic AC, T, Gs. Epigenetics is really modifications to that tells the cell how to use those genes. If you used all 20,000 genes that you have in every cell at all the time, that would be a disaster. So we have to use some of our genes more or less at any given time, in any given unique cell. So there's epigenetic modifications or DNA modifications that can open up your chromatin and make those genes being used, sort of like an on-off switch, right? It's the on switch, and this is what 5-hydroxymethylcytosine is. And there's also off switches, which is methylation, right? This is actually a way to close chromatin and make a gene unaccessible. We're really focused on this 5-HMC. When we see a lot of 5-HMC, which I've denoted by a blue lollipop, and this is just a random gene, so at a transcription start site is the TSS, a transcription end site is TES, so this is just the length of a gene represented in your genome. When we see a lot of 5-HMC, we know that that gene is generally going to be transcribed and open and active and being utilized. We see a lot of 5-HMC, for example, on the MYC-N gene for patients with MYC-N amplified tumors. In contrast, as I mentioned, if you see a lot of methylation, those genes are generally not being used and closed, and those are silenced. So we're very fortunate that there's a chemist on campus. His name is Xuan He. He's a Howard Hughes investigator, really just a brilliant scientist who's identified many of these things, chromatin modifications, particularly of DNA and RNA. And we were able to work with our patients at the University of Chicago and collect cell-free DNA from 32 different patients in a discovery cohort, another 27 in a validation cohort, as well as some well-children to controls. And I'm just going to simplify a lot of data to say we can find neuroblastoma signatures and actively use neuroblastoma genes in patients with lots of disease. One thing I should mention, the real challenge of liquid biopsies. And diagnosis, if there's a child who unfortunately has widely disseminated stage 4 disease, or stage M disease, I should say, they shed a lot of cell-free DNA. Almost all the cell-free DNA that we pick up in that blood is going to be coming from the tumor. For a patient who has reached remission, is in a CR, the Curie score is 0, hopefully they don't have any tumor. We will still be able to find cell-free DNA. Everybody here in this room, I could get your blood and I could identify circulating DNA in that blood. Our immune cells shed that DNA. Some of our cells that line the blood vessels will shed that DNA, and other organs throughout the body might shed trace amounts. So there's always going to be some background normal cell-free DNA floating around in the blood. So when thinking about a test for residual disease, or MRD, very similar to how my leukemia colleagues think about, can we pick up 1 in 100,000 cells, we have to think about how much of that DNA that we get is actually from neuroblastoma, and how much of that DNA is actually from normal tissue that should just be there. And that's really the big challenge when we're thinking about tracking disease over time. And so when we did this initial analysis, we clustered, we had 127 blood samples. We sort of said, which of these samples look similar to the other samples based on their 5-HMC profiles, and found 4 different samples, or 4 different sort of basic sets of clusters of different types of samples. One, as you can see in sort of this cluster 1, these are the kids with lots of disease burden. If we look at sort of how much neuroblastoma 5-HMC are we seeing, it's a lot. So on this, the y-axis is essentially a relative score. So they had the most circulating neuroblastoma DNA. As patients go through therapy, they generally go from cluster 1 to cluster 2 to cluster 3, and hopefully they make it to cluster 4, which is generally the cluster where we see all our well children, a lot of our off-therapy kids, and they have profiles that we think of as normal blood. And very intriguingly, in some of our early data, we actually took our cluster 4, which is our normal blood, and we said, can we actually pick out who are the ones who subsequently relapsed, even though they didn't clinically have disease, they didn't look like they were they looked like they should be fine, and can we differentiate them from the kids who were fine and looked like they didn't have disease and ultimately remained in remission? And the answer is we actually did see some difference there between those samples. As sort of an early hint that yes, we can use this technology to actually pick out, perhaps with some increased precision, who really has disease from who doesn't. And we can think about tracking these scores, sort of this neuroblastoma burden over time, and we can say, okay, at diagnosis, most patients with high-risk disease do unfortunately have metastases, so they tend to have very high scores, but can we kind of separate out over time who has a lot of circulating neuroblastoma DNA versus those who don't? And this is just effectively a conceptual slide that I'm showing here to think about that. And these are the real data, all right? So these are thousands of samples now from patients on 1531, where we can see, that sort of exact same progress, right? Where many kids at diagnosis, at baseline, that's that BL, will have very high neuroblastoma scores, and hopefully as they go through therapy, we see those scores coming down. And one of those questions that we're asking right now is, can we predict who's not going to respond in the same way using those baseline scores? Can we understand the difference of who some of those good responders versus poor responders are? On that far right, we have those relapse samples, RL. What's the difference between them and the diagnostic samples? Those are all questions that are under active investigation really as we speak. And I'll compare this actually to the data that came out of Boston. Again, this is all very preliminary, so no Twitter, please, or I guess X. But very similar data that you can get through multiple technologies. So this is the same samples, like I said, right? We split the DNA, they did their assay, we did our assay, and we actually get very similar results. And I think you can appreciate from the trends of, here they're looking at percent tumor, where they're saying how much is neuroblastoma DNA versus how much is normal DNA, which I would argue that the plots are in many ways very similar and perhaps complementary to the data that we're generating. But as I said, we can sort of start thinking about neuroblastoma response in a very different way from what we typically have done, right? As I mentioned, when a child is diagnosed with neuroblastoma, we don't really have any time point assessment of how they're responding to therapy until 5 cycles in after they've gotten surgery. With this, we can start asking some interesting questions, such as who doesn't have a lot of circulating DNA and after 1 cycle of therapy it sort of stays that way. We've got a group of kids who have a lot of circulating neuroblastoma DNA at diagnosis, and that clears very rapidly. And I'll contrast to the kids who don't clear their cell-free DNA very rapidly. And I think in the leukemia data, this is quite clear. And I think there's some emerging data in solid tumor that says time to clearing, time to CR might matter, right? If you get into remission sooner, do those patients have a different outcome than if you get into remission later? We actually have never been able to study this in neuroblastoma, and I think we're starting to have a way to perhaps ask these questions and understand sort of those time point questions in ways we weren't able to before. And again, this is very much ongoing work. And we can also look at other features, right? Because we are looking at what genes are actively being used, we can look at other neuroblastoma signatures that we think are important. This was a paper we published last year just looking at, as Dr. Thiel mentioned earlier, mesenchymal and adrenergic cells. Those have very defined RNA signatures. We can find those in our cell-free DNA using 5-HMC, right? And we can track those over time. We can understand, perhaps what patients are having increased mesenchymal scores or increased adrenergic scores, and again, are starting to look at what that means, and again, very replicable in the ANBL 1531 data as well. So moving to RNA. Araz, unfortunately wasn't able to hang out this afternoon, but this is data from CHLA and the group there, both Shahab and Araz. They have been looking at this, and this has been particularly prominent in NANT, looking at this thing called the LD5, so effectively looking at 5 genes that we know are highly expressed in neuroblastoma, and can they identify expression of those genes both in the blood as well as in the bone marrow. And this is, on the left, a paper that they published back in 2017 where they showed that you can find it in both. Perhaps bone marrow might be a little bit more sensitive, but certainly that this is a well-correlated biomarker using this RNA expression panel. More recently, they then looked at this actually over time in a series of COG patients and showed that if they were able to detect circulating neuroblastoma RNA at the end of diagnosis, that portended a worse prognosis than if they were not able to detect circulating neuroblastoma RNA. We just heard a talk from Dr. Scholler about DFMO at end of therapy. One of my questions is always, well, what is actually the minimal residual disease status of those patients? We don't really know. That's never been looked at. I think something that with this kind of technology would be a very interesting question to ask. And I'll tell you that our European colleagues are, I would say, well ahead of us in this game. So this is a study that was recently opened across SciAPin, which is the European version of the Children's Oncology Group. This slide was a courtesy of Leif Teget, as well as Dr. Tashna Mandel. They are running the study where they are actually using cell-free DNA and cell-free RNA and guiding therapy based on this. So they feel confident in their studies. They've validated this across multiple labs across Europe, and they can show that this is reproducible and correlates with patient response and outcomes. And so they're actively, prospectively evaluating liquid biopsy patients, or liquid biopsies and pediatric cancer, and making decisions based on this. So they're randomizing 150 patients. This is starting in the relapse with monthly liquid biopsy testing. They're testing a lot of the things I just showed you. So mRNA, so sort of that LD5 panel, but the European version of that RNA. They're looking at cell-free DNA, specifically targeted panels, I would say similar to what I showed you with Dr. Moset's data, looking at things like ALK and McN and other mutations. And they're also trying to look and say, can they detect MRD? And if they do detect MRD, right, if they can say in the blood that a patient isn't responding the way they want to, can they actually change therapy based on this? This is all being collected very centrally. There's a large trial database that's supporting this, a clinical decision support tool for those clinicians and families who might not be as familiar with using this, and also talking about quality of life and how does this affect care, and how does this affect sort of the families and their understanding of this disease. So I think this is going to be a very interesting trial, and I think some very exciting data when it's available. So I'll conclude again. So as I hope to have convinced you, liquid biopsies, really just, like I said, a fancy blood draw to understand the primary tumor, the metastases, and the tumor environment. I do think truly that these have enormous potential for changing how we think about monitoring disease, how we think about decision making in terms of therapeutics, for all the patients that we see. But as I said, I think there just is a little bit more work to be done in terms of which test, when. I showed you a lot of different options. And the data is being collected, and we're studying right now. And I think there's a lot of opportunities to mix and match data. For example, the samples that we have and the samples in Boston that are all coming from the same patients. Looking forward to doing that. So more to come, but I think a very exciting emerging technology. So I'll stop there. Thank you all for your attention, and happy to take questions. And of course, thank the patients and families, funding sources, everybody who worked on this.
Anyone have one question?
Yeah. Yeah, hi. Thank you for that. I was curious that covered mostly patients who are maybe in treatment, but thinking about patients who are in remission, you talked about predictive modeling a little bit. Is there a world where you guys are considering evaluating patients who are in that stage that you can kind of assess, what's the propensity or likelihood or probability of relapse?
Absolutely. I think that's a wonderful question. In terms of the samples we have right now, it's harder to get those samples in sort of a routine way, so that hasn't been the focus of the off-therapy samples. However, I would argue that a lot of the data we're getting on patients who are in early remissions, who are still on therapy, I think the same data likely applies. But I think you're absolutely right that evaluating these in the off-therapy setting is absolutely a priority, so that, if we see circulating tumor go up, right, circulating tumor DNA, I think that's a good indication. But what are the roles for some of these other tests and targeted testing? I think there's a lot to learn, but I do think that has great potential.
Thanks.
Another question? Go ahead.
As parents, how can we advocate for our kids in getting these liquid biopsies? I know that we've had some institutions do it, some don't, and insurance, in our experience, doesn't pay for it. So, after your presentation, I want to go to my son's doctor and say, when he's done with treatment next month, I would like to have another liquid biopsy because we got one at the beginning. And then maybe down the road, as he's in remission. So how do we as parents advocate for this kind of thing?
No, that obviously is the million-dollar question, right? So I will tell you that this is a rapidly evolving field that there's a lot of us thinking about. Most of these tests that I showed you are not CLIA-CAP certified, meaning they can't be given back to patients, although there are people working on that. Some centers have that, and some centers are using commercial vendors. So there are plenty of commercial vendors out there that will look at cell-free DNA and try to look for mutations. I think the problem with those is that they're not pediatric specific, they're not necessarily neuroblastoma specific, and I think there are many of us who would argue that we need that for our patients. In terms of insurance and approval rate, I mean, I think that's the work that we're doing now. It's hard to convince insurance to approve of something until we show them that it is beneficial. And that's exactly what we are working on.
Yeah, so then I think too, what if I went ahead and just asked our doctor to get this? So we've worked with some doctors who've wanted it, and obviously they will look at the results and they know how to maybe read them or
Interpret, yeah.
yeah, and so I guess that's the other component. We need to be able to work with somebody who wants to look at this information.
Yeah, no, and again, you're absolutely right. I mean, this is a very new technology, and there's some of us who are used to seeing this. And I would say in adult oncology or medical oncology, this is much more the norm because these tests have been looked at and certified and FDA approved for many different adult cancers. We are, unfortunately, a bit behind in pediatrics because we can't use the adult assays as well, because they're just not geared towards the mutations that we see. They're not geared towards finding MICA amplification. They can't report that out, for many of those tests. And of course, there are going to be some exceptions, and I don't want to overgeneralize. And there are some centers where, yes, some doctors will routinely send that because they believe in it and they believe in sort of the early data. It's an evolving field is really the best I can give you, right? I mean, I think if you ask me this question in 5-10 years, I would say it's probably going to be standard.
Okay, one question here.
In regards to patients that are in remission, depending on where they're treated, it could be different as to how frequent this lab draw is done for a patient that's in a maintained remission. What is the recommended frequency on getting this lab draw done for a patient in remission?
So as I said, a lot of this is still very much in the research stage, so there is no recommended frequency. I think for those who are getting liquid biopsies right now, it's very much between the family and the provider as to what they think will be useful. There are, as far as I'm aware, really no data or guidelines in pediatrics to answer that question in a meaningful way.
Anyone else? That's it? Okay.
Yeah, so Dr. Desai was, what does it take to get these tests validated? I mean, I think that's sort of the question here, right? So it is challenging. And there's a lot of rigor and reproducibility that has to go into this, right? I mentioned this CLIA CAP certification a couple of times, and that's really the gold standard by which clinical laboratories are able to report tests back to patients. Many of these tests, because they are using advanced genomics and sequencing, are sort of newer and sort of less well validated, although of course those tests are online for tumor samples. So it's a matter of doing lots of them. I will tell you in the Children's Oncology Group, we're actively discussing how do we incorporate this into our trials, how do we incorporate this into getting this back to patients. And the answer really is we need more samples, we need more data, we need to keep pushing forward with both making tests available and also working with entities like the FDA to say, how do we actually get this, in sort of a marketable product. So I mean, that's I don't know if that's answering your question on me, but.
Folks like Mark are studying this on these large trials so that they can eventually move towards it being validated so that it can be used clinically. A lot of it isn't ready for prime time to make clinical decisions quite yet, but that's the goal. The goal is that we will be able to some more commercial ones that might be out there or ones that are certified to be done, like we follow a specific thing, but to actually look at response and disease burden and things like that takes time to validate and to know what truly correlates with what's going on clinically, and that it's just not a spurious test. So we need to know what to do with that information as well too. But that's why it's being collected on some of these larger trials so we can move towards exactly what.
I mean, we're looking at this on 1531. We're already collecting the samples for 2131. The goal, I will tell you on all of these calls, is how do we get this to patients in a way that is meaningful and informative. That is absolutely the goal.
Anyone else? No other questions? Okay. Okay. Thank you, Dr. Applebaum.
Thank you.